ambassador to small business, to the business community, what he's learned from the business community about what our needs are. So, Dr. Stevens, would you please?
About a year ago, Reynold Jennings charged Bob and I to visit the businesses to find out what they needed in their health and wellness programs. And of course, it's a very various field. Everybody needs something different. The first thing we found out is there's chaos out there. They don't know what to do, what the ACA Act's going to do, how it's going to affect them, and there's total confusion, and it's probably going to stay that way. But if you can imagine in any health and wellness program, what a plumbing firm needs and what a law firm needs are two entirely different things. What a small business needs in Paulding County or Douglas County is different than what they need in Cobb County. And so it's a very various field of what all these people need. You know, 80% of all companies have less than 50 employees. And so the real question is, what do you need in a health and wellness program for those people? Same thing, 80% probably in most all jobs are created in the people that are most of you in this room. And so you have to really design a program that's for different things for different people. And probably our program will end up finally being a cafeteria style thing. So what you need, you can pick off of the chart and say, most of the educational things, I'm going to put in a plug here from Wellstar, are free. They can come to you, starting a webinar program right now, which if you've got a room with a TV in it, you can sign up at a specific time and do the webinar, which is good. And I'll admit, even being in a position, I didn't know was such thing as a DOT physical until a year ago. If you drive a big truck, you've got to have a physical to get a license, and you've got to have a physical every year. Who does it? Who pays for it? How do we get that done? What do you do with workman's comp? Workman's comp for a plumbing firm is different than for a big firm. But anyway, all of these things have to be solved, and the small businesses need help in doing this. And I hope we're going to have this program that is in the process is there. Wellstar will be your go-to person to get that, to solve those problems.
Thank you, Dan. I want to have an opportunity now to talk about our panel. David Cole is a partner with Freeman, Mathis, and Gary in the Labor and Employment Law section, and also the practice group leader of the firm's data security, privacy, and cyber liability practice. In his employment law practice, Mr. Cole represents businesses and local governments in all aspects of employment law and litigation, including discrimination claims, wage and hour claims, family and medical leave claims, non-compete agreements, and trade secret litigation. Mr. Cole also advises employers on personal policies and practices and helps them implement documents like employee handbooks, employee contracts, arbitration agreements, and severance agreements. Mr. Cole also advises and represents businesses in the unique legal issues arising from technology and internet in the workplace, as well as their health care obligations under the Affordable Care Act. Dr. Kreifer earned a degree in chemistry, summa cum laude, from Temple University in Philadelphia, followed by medical school and residency in internal medicine at the University of Pennsylvania. After working as one of the first hospitals for Kaiser Permanente in Hawaii, that's great because I used to live in Hawaii, and 2 years as a teaching attending as SUNY Syracuse, she moved to Kaiser Permanente in Georgia in 1998. Dr. Kreifer spent 15 years in a number of clinical roles, including primary care provider, hospitalist, and urgent care provider. In addition, Dr. Kreifer held progressively larger administrative roles, including associative medical director for primary care, associative medical director for specialty and acute care, and finally associative medical director for hospital, acute care, and resource stewardships. In 2013, Dr. Kreifer accepted the position of Vice President for population health management, where she is building population health programs for the WellStar ACO, WellStar Health Network, and other populations. In addition, Dr. Kreifer serves as the co-medical director for the newly launched Piedmont WellStar Health Plan. Dr. Kreifer is a well-regarded speaker on the topic of population health and has participated in a number of forums in the past year. Dr. Shea, Harry Shea, is the Director of Consumer and Government Business Lines at Kaiser Permanente, Georgia region. In this capacity, she is responsible for the strategy, product, sales, and overall performance of the small business, Medicare, Medicaid, and individual and family business lines. Prior to Kaiser Permanente, Dr. Shea had served in leadership roles in various healthcare companies for over 15 years, including Harvard, Pilgrim Healthcare, and Tufts Health Plan, two of the nation's top health plans, as well as Dignity Health, the 5th largest health system in the country, operating 50 hospitals. Dr. Shea received her doctorate in pharmacy from the University of California, San Francisco, and her master's of public health from the University of California, Berkeley. She volunteers her time on the board of Meals on Wheels Atlanta, an organization devoted to ending hunger in senior population. She lives in Decatur with her husband Garrett and 6-year-old son Jay. And our beloved Austinians began his career in insurance in 2009 when he began selling for Aflac. Since that time, he has branched out as his own agency in Marietta. Austin has worked with small groups and individuals in recent years in helping them navigate the world of the Affordable Care Act, also known as in the industry as the ACA. Bringing his past in voluntary benefits to the table, he is able to help bridge the gap financially between the deductible and the out-of-pocket expense. Austin has extensive knowledge in long-term care planning as well as disability and other specialized lines. He's a graduate, 1998 graduate of Johnson & Wales University in Providence, Rhode Island, with a BA in Culinary Arts. Also, he's an Eagle Scout and currently Vice President of South Cobb Business Association and the 2016-2017 President nominee for the South Cobb Rotary. As you can see, we have a tremendous panel today. Let's give them a round of applause. So we're going to begin with a question for David Cole. Okay, David, I'm going to give you this.
Oh, okay. I can probably just...
You could probably just talk without it, actually. Okay, David, what is happening currently with ACA, and how will the Supreme Court decision on King versus Burwell affect small business?
Okay.
Big question.
What's happening currently with the ACA? Well, assuming the audience is mostly small business, it's probably not actually impacting you a whole lot. Currently, the ACA, as far as the employer mandate, is in effect for employers that have 100 or more employees. And the requirements they have this year are that they have to provide qualifying health insurance to at least 70% of their full-time employees, which means those employees who work 30 hours or more per week. Next year, that percentage will rise to 95%, and that's where it will stay. You have a question already? They have to offer the insurance, but the offer that they provide must be made affordable to the employee. And well, not necessarily. To be affordable to the employee, it cannot cost your employee more than 9.5% of their W-2 wages to pay their share of the premiums. So, depending on how much your employees make, it's possible the employer would have to subsidize some part of the premium to get it down to that level. For employers that have 50 to 99 employees, this year they're entitled to transition relief. It means that they're normally covered by the employer mandate, but this year they don't have to make that offer of insurance. They won't have to make that until next year. Employers with fewer than 50 employees, they're not covered, so no obligation for you to offer insurance, although there are options for you through the healthcare exchanges. It's called the SHOP exchange for small employers to buy insurance through there, so that's something you might want to consider. What Dr. Block is referring to is King versus Burwell, which is a pending Supreme Court case. It was argued back in March, and it's anticipated that the decision will be issued this month. The Supreme Court issues its decisions every Monday, and so it could come next week or the week after that, but very soon. Just by a show of hands, are any of you familiar with what I'm talking about when we talk about King versus Burwell? Very interesting. Okay, so I'll operate based on that assumption. You might remember the Supreme Court case a few years ago. Everyone knew about that. It was a big, big deal. This is equally a big deal, but I guess the issue is something that only a lawyer can appreciate. It's very technical, so it's not as sexy, and I think it's not getting as much attention, but the effects of it could be equal or greater than the prior case. So what's at issue in this case is whether or not individuals who buy insurance at a federally run exchange are entitled to receive tax credits and premium subsidies provided through the federal government, or whether those tax credits and premium subsidies are only available at exchanges that are purchased through a state-run exchange. And so, in case you're not familiar, part of the Affordable Care Act was to set up these health exchanges, healthcare.gov, where you could go and buy insurance. Initially, all of the states were expected to create their own healthcare exchanges. But then the statute was amended to provide the option for states to opt out, in which case the federal government will step in and create a federally run exchange for them. And the way the numbers played out, 34 states opted out, and the federal government is running a federally run exchange in those states, including Georgia. Only 17 states actually chose to have their own healthcare exchange. So the question is, when people go and buy healthcare through an exchange, they're normally entitled to get premium subsidies and tax credits. The question is, can you get those at the federally run exchanges or just at the state-run exchanges? This is a really important issue that you might not realize for two reasons, really. The idea of the Affordable Care Act is to get as many people as possible, and really everyone in America, insured. So one of the ways they do that is through the individual mandate, which says everybody has to buy insurance or else they're going to have to pay a tax. That's what the prior Supreme Court case was all about. However, there's an exception to that says if the cost of buying health insurance is going to cost more than 8% of your income, then it's not affordable and you actually don't have to buy insurance through an exchange or otherwise. And so for a lot of people, they actually need these premium tax credits and subsidies to bring the cost of the insurance down to a level that's low enough that they can buy it. Because if without those subsidies, then the insurance will be deemed unaffordable, they don't have to buy it, and they will essentially leave the marketplace. And in order for this whole scheme to work out, you need everybody in the marketplace paying premiums and buying insurance. Otherwise, you're just going to have the older and sicker people buying insurance, and the younger, healthier people aren't going to be buying insurance and paying premiums to balance out the risk across everyone.
Who's paying for them when they don't have insurance?
Yeah, you are. The private payers, essentially. If they
I just want to make sure I was on the same page.
Yeah. I mean, they go to emergency rooms without insurance, and the hospital pays for them, and then the rest of us who have insurance pay higher rates because we have to spread the cost across as many other people. So if suddenly premium subsidies are not available in 34 states that have federally run exchanges, you can imagine the flood of people that are going to leave the insurance marketplace. Likewise, the employer mandate requires large employers to make this offer of coverage to employees or else pay a penalty. Well, the interesting thing is that this penalty is not triggered unless and until somebody in their workforce goes to a health insurance exchange, buys insurance there, and qualifies for a tax credit or premium subsidy. So if the tax credits and premium subsidies are not available any longer, then there will never be a trigger for a penalty against an employer under the employer mandate. And you will effectively have no employer mandate in any state that has a federally run exchange. So the reason this issue has come up is because the part of the Affordable Care Act that creates these tax credits and subsidies says that a subsidy is available to an employee who, I actually have some notes here, I think I've got it memorized by this point, who buys insurance, and this is a quote, through an exchange established by the state pursuant to Section 1311 of the Affordable Care Act. So it's those words, an exchange established by the state pursuant to Section 1311. The argument is A federally run exchange is not an exchange established by the state. It's established by the federal government. And the federal government exchanges are not established under Section 1311 of the statute. They're established under Section 1321 of the statute. So how can you say they get federally run exchanges? Well, the other side says, well, the part that creates the federal government exchanges says that when the state doesn't create an exchange, the federal government will step into its place and, quote, create such exchange. So they're saying, oh, if you're saying the words create such exchange, you're creating the exchange that is talked about in Section 1311, the state-run exchange. And so this is why I say it's only something that a lawyer should truly appreciate, but this is a really interesting statutory construction issue as to what the meaning of the law is. And they also said, look, you've got to construe this statute as a whole, because there would really be no point to having federally run exchanges if tax credits and premium subsidies weren't available there, because without them it becomes so unaffordable for so many people they wouldn't buy insurance. So those are the two sides of the issue. The oral arguments were very interesting. As you might expect, the quote-unquote liberal justices, Sotomayor, Kagan, Breyer, and Ginsburg all seem clearly to believe that the subsidies should be available because they don't want the whole Affordable Care Act to unravel. The conservative justices, Alito, Scalia, and Thomas, clearly seem to be favoring the other side that said, no, this is strict construction, the statute says this, and we can't be concerned about what the effects will be. Our job is to interpret the law. So Chief Justice Roberts and Justice Kennedy are going to be the swing votes. And however they decide, whichever side they join, that's going to be the result. So there could be a few different results. It could, if they find in favor of the government, then it'll maintain the status quo. Everything will continue working as normal, and everyone will continue to get subsidies and tax credits at the federally run exchanges. If they side with the petitioners and say that you can't get the tax credits, then frankly, I think the Affordable Care Act is going to start to unravel. You will not have an employer mandate in the federally exchange states, such as Georgia. You are going to have people not able to afford insurance any longer, thereby exempting themselves from the individual mandate. You're going to have people leave the marketplace, and that's going to affect insurance premiums all around. I think if it continues this way long term without change, you will probably see businesses moving to federally run states where there isn't an employer mandate. And likewise, you will probably have employees or workers move to state exchanges states where they can get insurance and get tax credits and premium subsidies, and where their employers will be required to make that offer of coverage. So you're going to have what's the word I'm looking for? The jobs and the workers are going to go and flee in opposite directions if you think about it long term from an economic standpoint. So that would be a very interesting result. So what are the options? During oral arguments, the Supreme Court talked about the possibility of finding in favor of the petitioners, saying that you can't have the subsidies, but recognizing the significant effects that could have, delaying the effects or delaying their decision for a year, so that states and various organizations could have time to adjust as necessary. And the third option, or the fourth option, would be a legislative fix. And they joked about that during the oral arguments. The lawyer arguing for the government, when Justice Scalia asked him, well, couldn't Congress just fix this problem? And he said, this Congress? But it does sound difficult for Congress to fix that problem given the way it works these days. But on the other hand, you could see the opportunity for politicians to, quote, come in and, quote unquote, rescue people's health insurance for them and make it affordable. I mean, so there could be some opportunity there to seize on. So that's something we'll see in the next few weeks.
Majority of the people that are in this audience are represented by small business. That's a pretty accurate statement, isn't it? Anything that have to do with this decision directly affects these people in the small businesses.
It will affect you as individuals in terms of the potential effect it can have on the marketplace and the rate.
What David said is right now there's not very much action actually in Georgia. I would say there's From a health insurance business perspective, we've done a lot of survey trying to understand, why the market's been, silent, and why, we haven't seen a lot of action from the broker space and also from small business employers picking up this as an option. So first of all, what is it? So what it is essentially, as I mentioned, an exchange vehicle where you and your employees can go on and select insurance. And the government has provided tax incentives for the smaller end of the small business. So if you have fewer than 25 full-time equivalent employees, and if they make on average less than $50,000 a year, there are some tax breaks and incentives for you as an employer to sort of offer this as an incentive for your employee and for your staff. And so the size matters, obviously, but the other thing that I think is a key consideration is, the choice. So in Georgia, we have what's called an employee choice market. And so when your employees go on the exchange, they don't have to select, they can select any plans on the exchange. So they have an option of choosing whatever works best for them. And so that you're not tied to, a specific health plan, for example. So you have that option of giving your employees the choice. Obviously, working with your brokers and your benefits folks to guide you through that decision process. But that kind of opens up the door a little bit for your employees to pick what's best for them. So those are the couple of key considerations I would say, as a small business owner, you want to consider, as the impact of the King versus Burwell come through, I anticipate you as a business owner will get a lot more questions about what the options are, particularly if you offer your employees' dependents the option to buy insurance through you today. And they have selected to go through the individual exchange. This decision can have material impact on what you may decide to do. So I would keep an eye out for it. One of the things that, as a health care provider in the Atlanta area, in Georgia, as David mentioned, we're a federally run exchange. This has material impact to our business. So we're looking at when that decision will come through. We are all very eagerly looking at, when Supreme Court will announce. And the decision could be that it's effective today, when they make the announcement. It could be retrospective or it could be prospective. So there are a number of different ways in which the decision can come through, or some other form that we haven't imagined, right? And so there's a lot of eagerly awaiting businesses in the area, but it does will have an impact on you, although not directly. I'll just add to that.
Thank you, Dr. Shea. Please give the microphone to Dr. Kreifer. I introduced Dr. Kreifer as VP of Population Health Management. So, what is population health management, and what can employers do to help their employees?
It's whatever I want it to be, because nobody knows. Population health management is really an approach to how we help an entire group of people improve their health or manage their health. It can be a small group of people in a small business, for example, or it can be a large group of people. We have an accountable care organization. We have 38,000 Medicare patients that we are responsible for improving their health and reducing their health care spend. That doesn't mean withholding care. What it really means is getting the right care in the right place at the right time. So I look at population health as 3 different things. I wish I had my triangle, because I have a triangle that I show everybody. But essentially, you got the top of the pyramid. Those are the sickest of the sick people. Those are the patients who have recurrent medical illnesses, who are in and out of the hospital, who are really struggling to manage their health. And those patients need intensive, one-to-one assistance and management. So I employ case managers to help reach out for those patients. One of the things that we are trying to do is to figure out how do we extend that beyond our current set of populations. It's expensive to have case managers managing patients. In the middle area is actually where most people live. Those are the patients who have diabetes or heart disease or hypertension, or they have whatever chronic illness. They're doing okay. They're managing. But if they don't take their meds, or they don't get the appropriate follow-up care, or they don't really understand how to manage their disease, they're going to end up in the red. To me, population health management is really about those people. It's about taking care of those people and helping individuals manage their own diseases. We spend 99.99% of our lives not in the doctor's office. So it's not about the doctor's office managing whatever's going on in your life. It's got to be about you. And it's hard. Medicine is complex, it's scary, lots of pills, etc., etc. Our goal is to help all those people know what to do and know how to manage their health. Then underneath there are what I call the green group, which is really two sets. One is the really truly healthy people. They exist. No significant medical problems. They don't take any medicines every day. They run marathons. They're really healthy. They get their preventive screening, and they're fine. All they need from us is to be reminded of when to get their preventive stuff done. There's another set in there which actually concerns me significantly. That's the set of people who don't know they have diabetes. They don't know they have breast cancer. They don't know that they have heart disease because they're not getting screened, and they're not seeing their physicians for anything. Those are the ones who go from I'm really healthy to I'm really not healthy. And so our goal is to get people in, to get screened for chronic diseases. Nobody wants to be told that they have diabetes. Georgia actually has one of the highest rates of diabetes in the country. We also have one of the highest rates of obesity. So we know that there are probably hundreds of thousands of people in Georgia who have diabetes who don't know they have it. So population health is really about addressing the needs of each of those sets of populations, and they're very, very different. I think that one of the things that I like about population health, and one of the things that we're moving towards, is that it's not cookie cutter anymore. Every patient is not the same. Every individual is not the same. Every diabetic is not the same as another diabetic. Our goal is to figure out how do we help one patient at a time with programs that we can put in place and teach people how to take care of themselves.
Well, that's great. Thank you, Dr. Kreifer. Austin, what are other options that employers can explore to lower healthcare costs?
There's many different options. I think one of the things a lot of people have started to embrace is what Dr. Kreifer said, is the wellness plan. It's kind of like turning a ship. You can't turn it on a dime. It takes time. But people are starting to really embrace the smoking cessations, the healthy diet, the exercise, the gym membership. I see Dr. Dan nodding. Those take time, though. It's not an instant light switch fix. But a lot of, even on the supplemental side, a lot of these supplemental policies are offering wellness benefits. You know, go get your routine physical, get this. Because people are realizing, okay, if I catch it now, it's a lot cheaper to treat than catching it later on. That's been one of the really big improvements in what everybody's doing, is if you can maintain a healthier employee through different means, diet, exercise, routine physicals, stopping smoking, this, that, and encouragement, that's really filtering through to your group, and it's decreasing the number of days lost for sickness, also decreasing spousal absence because I had to take my spouse to the doctor, I had to go have surgery with them. But it's that kind of a paradigm shift now of, okay, yes, we're an insurance company. Humana's one that I'll pick on. They came out with a program called Vitality. They rolled it out in individuals. They rolled it out in groups. It's the carrot and stick. Okay, if I can lose 5 pounds, I get, you know, my next little gold medal here. And it's a system of checks and goals too. But they're taking that approach now on a major side to encourage people to go out and be healthy. So there's more of that, and it's transcending more into groups and employers hosting things such as, you know, the 5K walks or the runs or this or that, or sponsoring employees to do that. So the whole wellness turn is kind of what's really changing a lot of stuff.
Thank you. Thank you very much. I have time for 2 questions. Any questions here for the panel, please? 2 questions.
I was wondering how many people in Georgia are actually affected. I don't mean
140,000 people.
It's about 500,000 people. One of the things that Georgia did not do was to expand Medicaid, and so there was a group of people who are already affected who make too much and too little at the same time. So, but 500,000 people is not an insignificant number of people. In my mind, it would be devastating from a purely medical perspective. We're not going to talk about politics here, because.
So about 5% of the population.
But it's also, we don't yet know how many of the people who have actually started. There are other people who have signed up for health insurance that didn't get subsidies, but they signed up for health insurance because they now have to sign up for health insurance, and employers are offering more and more health insurance. So there's 500,000 people who are going to lose their subsidies, but there's probably another 500,000 people who are going to lose their employer coverage. And that's not insignificant. Those are the people who are not going to go to the doc, not going to take care of their stuff. They're the ones who are not going to show up for work because they're too sick. Or worse, they're going to show up for work when they're sick and not do as good a job and get everyone else sick and then be out for longer because they didn't get it taken care of.
Is there one more question? Anybody, please?
In your opinion, with the affordable health care, the thought was that it also would decrease all the people who were just going to ER. In your opinions, has ER lessened? Because my understanding it has not, and therefore, how can we fix it?
I'll answer it. So, no, it hasn't. And there's really two reasons for that. One is there's still a bunch of people who are not covered, and the other is that we have a shortage of primary care physicians. It's very, very difficult to get in to see a primary care physician. We are underserved in that respect throughout the state of Georgia. If you can't get hooked up with a primary care doc, the other thing is that we've created a culture where what do you do when you're sick? You go to the emergency department. So it's going to take a little while before the culture shifts and people start to realize that their medical home is their primary care doc.
To answer that from an insurance standpoint, a lot of people got a really rude awakening come January 1, 2015. Insurance companies decided to address this. An emergency room visit now is defined as broken bone, heart attack, stroke, can't breathe, major medical. The way they've changed this is you're now responsible for 100% of your deductible. It's no more copay. So if you got a $2,000 deductible, your visit to the doctor, to the ER for something, I stubbed my toe and I need a stitch, is going to be $2,000 plus your copay. What they've done is partnered with urgent care clinics. They're trying to financially drive you to the urgent care clinic unless you're required to be transported by an ambulance, for lack of a better term. So they figured out, okay, we're going to hit you in the pocketbook where it really hurts. So a lot of these new policies out, when you go read your fine print on the back of your card ER visit, there's no copay. It's 100% and then of your deductible. So that's how they're funneling a lot more people to an urgent care clinic, because an urgent care clinic, correct me if I'm wrong, can take care of, the 2 stitches you need and the bee sting and I got a boo-boo and it's just bruised. And you leave the emergency room for the trauma, gunshot, heart attack, stab wounds, chest pains, can't breathe, I think I'm having a stroke. And at the end of the day, it really benefits that person who needed care most, because there's not somebody in there. I got a hangnail and it's 3 a.m. Can you get it taken out for me? And that's what a lot of people were doing, was treating the ER, but now they're taking it, so please go see your urgent care doc in a box, and it's a lot cheaper.
Can I, okay, just add to that. I think to your question, if you think about the sheer number of people that are insured versus before Affordable Care Act was put in place, there's just a lot more people that are insured. And people that are now insured are people who haven't had insurance in the past. And those individuals are going to be less used to going to a primary care setting, for example, or even an urgent care setting. They're more used to going to the emergency room as their way of seeking out care. So I think I think the incentives put in by the insurance companies, but there's also sort of a behavioral change. People are going to have to learn that the best place to go actually for care is with your primary care. And we have to make sure that there is not a capacity issue from a provider perspective.
Great. Well, thank you very much. That's the end of the panel discussion today. I hope you learned. Our next speaker for the next few minutes is Krista Tillman, and she's going to be talking about a very important subject, which is automated external defibrillators or heart defibrillators in the workplace. Very important issue. Krista?
Thank you for having me today. Like you said, I'm a level 3 EMS instructor. I teach EMT and paramedic school and all the continuing education for Puckett and some of the other EMS providers. I am very passionate about AEDs as well as early CPR in the workplace. It increases our survival for our community. So statistics from 2014 from American Heart Association was that approximately 400,000 people suffered sudden cardiac arrest, which is different than your heart attacks. This is where they had no symptoms, they were talking to you, and all of a sudden they had a massive heart attack. Approximately 40% of that number were witnessed by someone, and only a third were treated with CPR. Most people are thinking, I don't think I want to be a part of that. They're scared of getting sued, right? That's why Good Samaritan law is out there. Because if we do our best to provide care, the law protects us. But with the AEDs, only 2% of that 400,000 actually had an AED. And mostly it's because of accessibility. A lot of people aren't educated, they're worried about the cost. In Cobb County, we have about a 6-minute 911 response time. Not bad. We're fortunate that our Cobb County Fire Department, they are paramedics and EMTs. So they can treat you while you're waiting on the ambulance sometimes when it seems like forever and time is ticking. It has been proven that the first 3 to 5 minutes are very, very crucial for CPR and AED. It increases your chance of survival by almost 40%. Brain death occurs after 4 minutes. So we can see how we need that AED and good training. So what I'm going to tell you about is a good thing is that Puckett EMS has partnered with some people in the community, and we have started EMS Cares Foundation. Our goal is to provide AED training and CPR training for free. Not the AED, that's about half price, but CPR training and the medical direction, and we will come out into your community. Powder Springs is our first initiative with the EMS Cares Foundation. We have provided them with 30 AEDs so far, and by the end of July, all police officers will carry an AED in their patrol car, as well as all the city council will be trained. So all employees will be trained in CPR. So I just want to tell you the statistics. Early, our national survival for cardiac arrest is 10% for the nation, and by having early CPR and AED, it increases our chance of survival to 38%. We're modeling after Seattle, Washington, who has a current survival rate of 67%. Cobb County, right now we're at 27% survival. Not bad. We're about 15% above the national average. But our goal over the next 24 months is to increase that to 40%. So if you have any questions, you can talk to me later, but I know I'm on a time crunch. But again, just the importance of having the access and the training. And our goal is to make Cobb County.
And in Princeton, New Jersey. And I had an MI, a myocardial infarction, before the shotgun went off for the tournament. And I was in Princeton. Princeton did not have a cardiac care unit in their hospital. There wasn't things called AEDs. I had to be ambulanced to Philadelphia to be cared for. It was obvious that I had, through the blood test, that I had a myocardial infarction. But it saved me. Luckily, I got to the hospital in time because I knew what was happening to me, and I saved my life. Otherwise, I wouldn't be speaking to you right now. But so much has changed over the last 30 or 40 years, and what's happening now. So I'm very appreciative of your being here to listen to our wonderful panel, and I'd like to have you give everybody a wonderful round of applause. If you have any questions for any of the panel, please come up and ask them. They'll be here for a couple more minutes, about 15 minutes, 10, 15 minutes. Please don't hesitate in asking. And now, whom do I give this to?